Welcome to Study Session 17, Settings of Healthcare. Introduction. This study session explores a number of issues relating to settings of healthcare in mental health practice. It will explore the principles of inpatient care. To help you understand, it starts by discussing emergency room psychiatric care. We will also look at the concept of community mental health and the principles of psychiatric home care. Principles of inpatient care. The principles of recovery-oriented mental health practice ensure that mental health services are delivered in a way that supports the recovery of mental health consumers. They are 1. Uniqueness of the individual. Recovery-oriented mental health practice recognizes that recovery is not necessarily about cure, but is about having opportunities for choices and living a meaningful, satisfying, and purposeful life. And being a valued member of the community accepts that recovery outcomes are personal and unique for each individual and go beyond an exclusive health focus to include an emphasis on social inclusion and quality of life empowers individuals so they recognize that they are at the center of the care they receive. Real choices. Recovery-oriented mental health practice supports and empowers individuals to make their own choices about how they want to lead their lives and acknowledges choices need to be meaningful and creatively explored. Supports individuals to build on their strengths and take as much responsibility for their lives as they can, ensure that there is a balance between duty of care and support for individuals to take positive risks and make the most of new opportunities. 3. Attitudes and rights. Recovery-oriented mental health practice involves listening to, learning from, and acting upon communications from the individual and their careers about what is important to the individual, promotes and protects an individual's legal, citizenship, and human rights, supports individuals to maintain and develop social, recreational, occupational, and vocational activities which are meaningful to them, instills hope in an individual about their future and ability to live a meaningful life. 4. Dignity and respect. Recovery-oriented mental health practice involves being cautious, respectful, and honest in all interactions. It involves sensitivity and respect for each individual, especially for their values, beliefs, and culture challenges. Discrimination wherever it exists within our own services or the broader community. 5. Partnership and communication. Recovery-oriented mental health practice acknowledges that each individual is an expert on their own life and that recovery involves working in partnership with individuals and their careers to provide support in a way that makes sense to them. Values the importance of sharing relevant information and the need to communicate clearly. Involves working in positive and realistic ways with individuals and their careers to help them realize their own hopes, goals, and aspirations. 6. Evaluating recovery. Recovery-oriented mental health practice ensures that and enables continuous evaluation at several levels. Individuals and their careers can track their own progress. Services demonstrate that they use individuals' experiences of care to inform quality improvement activities. The mental health system reports on key outcomes that indicate recovery. These outcomes include housing, employment, education, social and family relationships, health and well-being. Functions of psychiatric nurse in inpatient psychiatric ward. 1. Provide for environmental safety, including protecting the patient and others from injury. 2. Perform psychosocial high-risk and physical assessment. 3. Promotion of self-care activities. 4. Medication management. 5. Assisting for somatic therapies. 6. Accurately observing and documenting the patient's behavior. 7. Providing opportunities for the patient to make his own decisions and to assume responsibility for his life. 8. Providing feedback to the patient based on observations of his behavior. 9. Participation in various therapies: psychotherapy, behavioral therapy, group therapy, play therapy, family therapy, etc. Individual interactions, formal and informal group situations, role play, advocating on behalf of the patient, and so forth. 10. Delivering psychoeducation. 11. Counseling the patient and the family members. 12. Cooperating with other professionals in various aspects of the patient's care, thereby facilitating an interdisciplinary approach to care. 13. Teaching social skills and stress management strategies. 14. Discharge planning and community referral and follow-up care. 15. Supervise the work of subordinates. 16. Maintain ward cleanliness. Principles of emergency room psychiatric care. Psychiatric emergency is a condition wherein the patient has disturbance of thought, affect, and psychomotor activity leading to a threat to his existence, suicide, or threat to the people in the environment, homicide. This condition needs immediate intervention to safeguard the life of the patient, bring down the anxiety of the family members, and enhance emotional security to others in the environment. Within the psychiatric emergency patient population, there are two subpopulations that pose particular challenges to the emergency care providers. The two populations consist of those patients present with intentional self-harm, including suicide, and the second is substance use, or there is a frequent overlap of these two issues, and substance abuse is a known risk factor for suicide. Substance use and abuse is a confounding factor in many emergency department visits. Since the 1960s, the demand for emergency psychiatric services has endured a rapid growth due to the institutionalization both in Europe and the United States. The institutionalization in some locations has resulted in a larger number of severely mentally ill people living in the community. There have been increases in the number of medical specialties and the multiplication of transitory treatment options, such as psychiatric medication. The actual number of psychiatric emergencies has also increased significantly, especially in psychiatric emergency service settings located in urban areas. Emergency psychiatry has involved the evaluation and treatment of unemployed, homeless, and other disenfranchised populations. Emergency psychiatry services sometimes can be accessibility, convenience, and anonymous. While many of the patients who use psychiatric emergency services shared common sociological and demographic characteristics, the symptoms and needs expressed did not conform to any single psychiatric profile. The individualized care needed for patients utilizing psychiatric emergency services is evolving, requiring an always changing and sometimes complex treatment approach. Triage of psychiatric patients in the emergency department. A mental health triage assessment tool is described as one that is on the reverse side of the usual triage assessment form. The format of the tool includes presenting complaints, to whom the patient will be assigned, and the triage code. For example, the complaint, active hallucinations, is to be seen by the ER physician and is a triage code urgent. Mood disturbance without suicidal behavior is assigned to the crisis intervention worker and the triage code is semi-urgent. Such a system provides guidance for the triage nurse and improves the flow and function of the department. Behavioral activity rating scales (BARS) consist of a single item describing the patient's activity on a 7-point scale. It was thought that such a scale would be more useful in the rapid-paced emergency department. The advantage that the BARS tool has is that in addition to predicting which patients will need psychiatric management interventions, such as sedating medications or restraint, it can also be used as a serial means of observing and documenting changes in patients' behavior and also improve communication between emergency care providers. One of the high-risk psychiatric triage challenges is that of suicide assessment. In addition to asking the patient about suicidal ideation and intent, factors that have been identified and tried nurses should evaluate include age, less than 19 and over 45, male gender, depression, substance use, previous suicide attempt, psychiatric diagnosis, previous psychiatric inpatient admission, social isolation, lack of support system, unmarried, recent significant loss, chronic debilitating illness, chronic pain, access to agents to inflict harm. Given the high stakes, getting the suicide assessment right is critically important. After the initial rule of triage, sorting or prioritizing, more in-depth mental health assessments could be more effectively conducted once the patient is in the treatment area. This would be a more thorough initial psychiatric assessment and include the categories of the more usual mental status examination (MSE), such as appearance, behavior, attitude, mood, and affect, speech, thought process, thought content, perceptions, cognition, insight, and judgment. Such an initial evaluation would be beneficial in identifying possible medical causes for the psychiatric symptoms as well as serving as a basis for the plan of care for the patient. Violence or agitation or restraint. Agitation can be caused by a variety of conditions, both medical and psychiatric. Assessment of patients who present to emergency departments in an agitated state should include a brief history and vital signs if possible in order to identify any medical problem that could potentially be life-threatening. History is critically important in determining whether the source of the agitation is likely related to a general medical condition, such as hypoglycemia, hypoxia, or neurologic problem. An exacerbation of psychiatric illness. Identifying the underlying etiology is key to treating agitation in the emergency setting. Alcohol and other mind-altering drugs are frequently the reason for agitation and violence in the emergency department. Withdrawal from alcohol and or benzodiazepines can also be a cause of agitation. De-escalation is a critical strategy in preventing the agitated patient from becoming violent. It is of note that the use of seclusion, restraint, or forced medication intended to calm the agitated patient has the potential for injurious side effects, both physical and psychological, although it is recognized that there are times when their use is unavoidable. Physical space should be designed for safety. Staff should be appropriate for the job. An adequate number of trained staff must be available. Objective scales should be used to assess agitation, and clinicians should self-monitor and feel safe when approaching a patient. Firm limits should be established in order to protect the staff and other patients, while giving the patients choices when possible. Restraints may be necessary if limits are violated in the care of psychiatric patients in the emergency department. Accurate communication between providers is essential. Initial approach during emergency. The initial approach to the patient should be warm, direct, and concerned. A quick evaluation to identify the nature of the condition and to institute care on the basis of seriousness is essential. The emergency staff should have basic knowledge of handling psychiatric emergencies. Medical legal cases need to be registered separately and informed to the concerned officer. Hospital security must be adequate to control violent and dangerous patients. History and clinical findings should be recorded clearly in the emergency file. Patient's condition and plans of management should be explained in simple language to the patient and family members. Types of psychiatric emergencies and their management. Suicidal threat. In psychiatry, a suicidal attempt is considered to be one of the commonest emergencies. Suicide is a type of deliberate self-harm and is defined as an intentional human act of killing oneself. Etiology. Psychiatric disorders. Major depression, schizophrenia, drug or alcohol abuse, dementia, delirium, personality disorder. Physical disorders. Patients with incurable or painful physical disorder like cancer and AIDS. Psychosocial factor. Failure in examination, dowry arousement, marital problems, loss of loved object, isolation and alienation from social groups, Financial and occupational difficulties. Risk factors for suicide. Age. Males above 40 years of age, female above 55 years of age. Sex. Men have greater risk of completed suicide. Suicide is 3 times more common in men than in women. Women have higher rate of attempted suicide. Being unmarried, divorced, widowed or separated, having a definite suicidal plan, history of previous suicidal attempts, recent losses, suicidal tendency in psychiatric wards. Certain psychiatric disorder where the patient may develop suicide include major depression. This is one of the commonest conditions associated with a high risk of suicide. Suicide in a major depressive episode is due to pervasive and persistent sadness, pessimistic cognitions concerning the past, present and future, delusions of guilty, helplessness, hopelessness and worthlessness, and derogatory voices urging him to take his life. The risk of suicide is more when the acute phase has passed and the characteristic psychomotor retardation has improved. This is so because the patient has more energy to carry out his suicidal plans now, though he might have been harboring them for quite some time. Schizophrenia. The major risk factors among schizophrenics include the presence of associated depression, young age and high levels of premorbid functioning, especially during college education. People in this risk group are more likely to realize the devastating significance of their illness more than other groups of schizophrenic patients do, and see suicide as a reasonable alternative. Mania. Manic patients may occasionally commit suicide. This is usually the result of grandiose. The patient may believe that he is a great person. Or wish to prove his supernatural powers. With this intent in mind, he may carry out some dangerous activity that can cost him his life. Drug or alcohol abuse. Suicide among alcoholics can be due to depression in the withdrawal phase. Also, the loss of friends and family, self-respect, status and general realization of the havoc alcohol has created in his life and caused the individual to wish to die. Personality disorder. Individuals with histrionic and borderline traits may occasionally attempt suicide. Organic conditions. Conditions such as delirium and dementia due to changes of mood like anxiety and depression may also induce suicidal tendency. Management. 1. Be aware of certain signs which may indicate that the individual may commit suicide, such as suicidal threat, writing farewell letter, 4. Giving away treasured articles, 5. Making a will, 6. Closing bank accounts, 7. Appearing peaceful and happy after a period of depression, 8. Refusing to eat or drink, maintain personal hygiene, 9. Monitoring the patient's safety needs, 10. Take all suicidal threats or attempts seriously and notify psychiatrists. 11. Search for toxin agents such as drugs or alcohol. 12. Do not leave the drug tray within reach of the patient. Make sure that the daily medication is swallowed. 13. Remove sharp instruments such as razor blades, knives, glass bottles from his environment. 14. Remove straps and clothing such as belts, neckties. 15. Do not allow the patient to bolt his door on the inside. Make sure that somebody accompanies him to the bathroom. 16. Patients should be kept in constant observation and should never be left alone. 17. Have good vigilance, especially during morning hours. 18. Spend time with him, talk to him and allow him to ventilate his suicidal plans or methods. 19. If suicidal tendencies are very severe, sedation should be given as prescribed. 20. Encourage verbal communication of suicidal ideas as well as he or her fears and depressive thoughts. A no suicidal pact may be signed, which is a written agreement between the patient and the nurse that patient will not act on suicidal impulses but will approach the nurse to talk about them. 21. Enhance self-esteem of the patient by focusing on his strengths rather than weaknesses, his positive praise and appreciation. This fosters a sense of self-worth and enables him to take control of his life situation. 22. Management of attempted suicide in the inpatient unit. 23. Assess for viral signs, check airway, if necessary, clear airway. 24. If pulse is weak, start IV fluids. 25. Turn patient's head and neck to one side to prevent regurgitation and instituted in case of self-inflicted injuries. Management of shock. 1. Transfer the patient to medical center immediately. 2. If there is no evidence of life, leave the body in the same position or room in which it was found. Move the patient in case suicide from a common living area, for example, dining room or TV room. 3. In case the patient has attempted suicide by jumping, do not leave the body in a place which is visible to other patients of the ward. 4. Inform authorities, record the incident accurately. 5. Contact local guardian and inform them. 6. Place an attendant outside the room where the body is kept. 7. One of the patients is transferred to mortuary or police custody. Take 2. 7. Once the patient is transferred to mortuary or police custody, clean the place with disinfectant solutions. 8. Hand over the patient's properties to the concerned authorities or relatives. 9. Carry out the institution formalities for death certificate. 10. The senior staff should discuss the incident in detail with all the staff and reassure them. The discussion should include possible lapses and preventive measures that need to be undertaken. 11. The care for the other patients should include the following. 12. Transfer all the patients away from the incident location. 13. Keep the patients in the center engaged by games and other recreational activities. 14. Serve food and medication to the patients earlier than scheduled. 15. Observe for any change in behavior. Inform the psychiatrist. Violent or aggressive behavior or excitement. This is a severe form of aggressiveness. During this stage, patients will be irrational, uncooperative, delusional, and assaultive. Etiology. Organic psychiatric disorders like delirium, dementia, Wernicke-Korsakoff schizophrenia, mania, agitated depression, withdrawal from alcohol and drugs, epilepsy, acute stress reaction, panic disorder, and personality disorder. Management. 1. An excited patient is usually brought tied up with a rope or in chains. The first step should be to remove the chains. A large proportion of aggression and violence is due to the patient feeling humiliated at being tied up this manner. 2. Talk to the patient and see if he responds. Firm and kind approach by the nurse is essential. 3. Usually, sedation is given. Common drugs used are diazepam 10 to 20 mg IV, haloperidol 10 to 20 mg, chlorpromazine 50 to 100 mg IM. 4. Once the patient is sedated, collect history carefully from relatives. Rule out the possibility of organic pathology. In particular, check for history of convulsions, fever, recent intake of alcohol, fluctuations of consciousness. 5. Carry out complete physical examination. 6. Send blood specimens for hemoglobin, total cell count, etc. 7. Look for evidence of dehydration and malnutrition. If there is severe dehydration, IV drip may start. 8. Have less furniture in the room and remove sharp instruments, ropes, glass items, ties, strings, matchboxes, etc. from patient's vicinity. 9. Keep environmental stimuli such as lighting and noise levels to a minimum. Assign a single room limits interaction with others. 10. Remove hazardous objects and substances. Caution the patient when there is possibility of an accident. 11. Stay with the patient as hyperactivity increases to reduce anxiety level and foster a feeling of security. 12. Redirect violent behavior with physical outlets such as exercise, outdoor activities. 13. Encourage the patient to talk out his aggressive feelings rather than acting them out. 14. If the patient is not calmed by talking down and refuse medication, restraints may become necessary. Following applications of restraints, observe patients every 15 minutes to ensure that nutritional and elimination needs are met. Also observe for any numbness, tingling, or cyanosis in the extremities. It is important to choose the least restrictive alternative as far as possible for these patients. Guidelines for self-protection when handling an aggressive patient. 1. Never see a potentially violent person alone. 2. Keep a comfortable distance away from the patient, arm length. 3. Be prepared to move. A violent patient can strike out suddenly. 4. Maintain a clear exit route for both the staff and patient. 5. Be sure that the patient has no weapon in his possession before approaching him. 6. If patient is having a weapon, ask him to keep it on a table or floor rather than fighting with him to take it away. 7. Keep something like a pillow, mattress, or blanket wrapped around arm between you and the weapon. 8. Distract the patient momentarily to remove the weapon, throwing water in the patient's face, yelling, etc. 9. Give prescribed antipsychotic medication. Panic attacks. Episodes of acute anxiety and panic can occur as a part of sweating, tremors, feelings of choking, chest pain, nausea, abdominal distress, fear of dying, paresthesias, chills, or hot flushes. Management. 1. Give reassurance first. 2. Search for causes. 3. Diazepam 10 mg or lorazepam 2 mg may be administered. 4. Catatonic stupor. 5. Stupor is a clinical syndrome of akinesis and mutism, but with relative preservation of conscious awareness. Stupor is often associated with catatonic signs and symptoms, catatonic withdrawal, or catatonic stupor. The various catatonic signs include mutism, negativism, stupor, ambitendency, echolalia, echopraxia, automatic obedience, posturing, malarisms, serotypes, etc. 6. Management. 7. Ensure patent airway. 8. Administer IV fluids. 9. Collect history and perform physical examination. 10. Draw blood for investigations before starting any treatment. 11. Other care is the same as that for an unconscious patient. Hysterical attacks. A hysteric may mimic abnormality of any function which is under voluntary control. The common modes of presentation may be hysterical fits, hysterical ataxia, hysterical paraplegia. All presentations are marked by dramatic quality and sadness of mood. Management. 1. Hysterical fits must be distinguished from genuine fits. See page 185 for difference between hysterical and epileptic seizures. 2. As hysterical symptoms can cause panic among relatives, explain to the relatives the psychological nature of symptoms. Reassure that no harm would come to the patient. 3. Help the patient realize the meaning of symptoms and help him find alternative ways of coping with stress. 4. Suggestion therapy with IV pentothal may be helpful in some cases. Transient situational disturbances. These are characterized by disturbed feelings and behavior occurring due to overwhelming external stimuli. Management. Reassurance. Mild sedation if necessary. Allowing the patient to ventilate his or her feelings. Counseling by understanding professional. Delirium tremens. Delirium tremens is an acute condition resulting from withdrawal of alcohol. Management. Keep the patient in a quiet and safe environment. Sedation is usually given with diazepam 10 mg or lorazepam 4 mg IV, followed by oral administration. Maintain fluid and electrolyte balance. Reassure patient and family. Epileptic furor. Following epileptic attack, patients may behave in a strange manner and become excited and violent. Management. Sedation, injection, diazepam 10 mg IV or injection luminal 10 mg IV followed by oral anticonvulsant. Haloperidol 10 mg IV helps to reduce psychotic behavior. Acute drug-induced extrapyramidal syndrome. Antipsychotics can cause a variety of movement-related side effects, collectively known as extrapyramidal syndrome (EPS). Neuroleptic malignant syndrome is rare but most serious of these symptoms and occurs in a small minority of patients taking neuroleptics, especially high-potency compounds. Management. The drugs should be stopped immediately. Treatment is symptomatic and includes cooling the patient, maintaining fluid and electrolyte balance, and treating intercurrent infections. Diazepam can be used for muscle stiffness. Dantrolene, a drug used to treat malignant hyperthermia. Bromocriptine, amantadine, and idopa have been used. Drug toxicity. Drug overdosage may be accidental or suicidal. In either case, all attempts must be made to find out the drug consumed. A detailed history should be collected and symptomatic treatment instituted. A common case of drug poisoning is lithium toxicity. The symptoms include drowsiness, vomiting, abdominal pain, confusion, blurred vision, acute generalized convulsion, oliguria, and death. Management. 1. Administer O2. 2. Start IV line. 3. Assess for cardiac arrhythmias. 4. Refer for hemodialysis. 5. Administer anticonvulsants. Victims of disaster. Victims of disaster are people who have survived a sudden, unexpected, overwhelming stress. This is beyond normally what is expected in life, like in an earthquake, flood, riot, and terrorism. Anger, frustration, guilt, numbness, and confusion are common features in these people. Management. 1. Treatment for life-threatening physical problems. 2. Critical Incident Debriefing (CID) is a special technique which is used to lessen the discomfort of the disaster victims. 3. Critical Incident Debriefing includes 5 phases: fact, thought, reaction, reaching, and re-entry. 4. In the fact phase, each participant is involved to share his or her perception of the incident. New information are integrated into a more understandable whole. 5. The thought phase builds on this information by asking participants to reflect the incident and to share what they were feeling personally during different times of the crisis. 6. In the reaction phase, participants are asked to evaluate the impact of the emotional aspect of the incident. For example, what was the worst part of the incident for you? Previously not discussed and less acceptable feelings are allowed to emerge in a safe environment. Knowing that other people are experiencing the same feelings make them realize that these feelings are normal behavioral responses to abnormal circumstances, and this brings a lot of relief to people who are under intense stress. Participants discuss stress-related symptoms they are during the incident or are experiencing currently. 7. The teaching phase focuses on specific cognitive, emotional, and spiritual strategies to reduce stress and ways to enhance group support. 8. In the final re-entry phase, the facilitator encourages questions and summarizes the process. Finally, individuals are referred to further counseling if needed. 9. Group therapy. 10. In selected cases, benzodiazepines are prescribed to reduce anxiety and induce sleep. 11. Referral to mental health service if required. 12. Educate the victims that these emotional reactions are normal reactions and are to be expected under the circumstances. Educate about the available services. 13. Teach coping strategies to avoid the development of the crisis. For example, strategies to be taught can resource and obtain support. Rape victim. Rape is a perpetration of an act of sexual intercourse with a female against her will and consent. Signs and symptoms. Acute disorganization characterized by self-blame, fear of being killed, feeling of depersonalization and derealization, recurrent intrusive thoughts, anxiety and depression are commonly seen. Long-term psychological effects like post-traumatic stress disorder (PTSD) can occur in some cases. Management: 1. Be supportive, reassuring and non-judgmental. 2. Physical examination for any injuries. 3. Gives morning after pill to prevent possible pregnancy. 4. Send sample for STD and HIV infection. 5. Explain to the patient the possibility of PTSD. Sexual problems like vaginisms and anorgasmia, which may appear later. We have come to the end of study session 17.